ourselves taking on the roles of carers for a condition we may know little about, and even less about the care responsibilities associated with it. This is a progressive, debilitating condition. It is complex and transforms the lives of patients and their carers. Difficulties tend to arise in the face of competing tensions as we attempt to balance the demands of caring for the patient with work demands, financial implications, maintenance of a stable family unit and environment, whilst being an active member within our communities. While external resources do exist within the community to take on the responsibility of caring for the patient with dementia, we find ourselves in a dilemma about making the choice between keeping the patient at home or admitting them into a care facility. This evening, Ms. Melaine Pillay from TAFTA, that is the Association for the Aged, will share with us the points to consider when we are faced with this tough decision. Melaine is a distinguished and visionary social worker leader with 34 years of unwavering dedication to the social development sector. As Chief Social Worker in the Department of Social Development, she provided strategic leadership, policy guidance, and oversight to social work services at a senior level. She also served as Executive Director at Child Welfare Durban and District, where she led child protection and community-based programs. Her commitment to professional standards and skills development led her to serve as facilitator and assessor at South Africa Maritime College for 2 years. Since 2018, she has served as Senior Manager, Social Work Services at TAFTA, where she continues to champion service excellence and position social work as an oasis of social well-being, a space of restoration, dignity, advocacy, and a hope for older persons and the communities they belong to. Melaine is deeply passionate about empowering people, strengthening families, restoring dignity, rebuilding lives, and reshaping communities. Ladies and gentlemen, during Melaine's presentation, please write any questions and comments using the chat function, both in Zoom and Facebook Live. Melaine, over to you.
Good evening. Thank you for this wonderful opportunity. I'm now going to share my screen with you because I have created a presentation that you can visually look at while we communicate about this. There's our TAFTA logo, decision-making for long-term care for people who are living with dementia. So at TAFTA, what we do is we support our loved ones through every season of their lives, especially when they become older. We find that dementia sets in. Now, one of the analogies that we use to describe dementia, and I'm sure you guys have heard this before, seeing this is the second part of the presentations, a tree losing its leaves. That's how we commonly, and in a very moving metaphor, we describe dementia and Alzheimer's disease. Now, I must mention that Alzheimer's is just one of the different types of dementia. So you have dementia being the umbrella and Alzheimer's being just one of those sorts of diseases. We visualize the brain as a tree, okay, where the leaves represent their memories, cognition, aspects of your personality that are gradually shed as the disease progresses. So we all begin as little shoots in our lives, and we develop over the years as we create memories, we enjoy events, we make life choices, we pursue a career, we build our homes, we get married, we have babies and grandchildren, and I just had my one recently, grandchild, that is 3 months ago, and then we retire and so forth. In dementia, what essentially happens is that the world shrinks and it becomes smaller. So the progression that you see from a seed all the way to a tree now is a backward decline all the way back to a shoot. Dementia is not a normal part of aging, neither is Alzheimer's. But we must always remember that it becomes more likely with age. We do have risks that are modifiable and risks that are non modifiable. Some of the risks that are modifiable are your lifestyle, your diseases that we live with, and all the comorbidities that we develop as we age. Dementia is different. It progresses differently for everybody. So because of the effect of dementia on your brain, different hemispheres of your brain are affected. And then this is why you have different symptoms with different people. But what is true and correct is that the symptoms will worsen over time. And sadly, the condition is ultimately life limiting. So how do we tend to this tree? Very important question. And the very straightforward answer is that we have to look at it decisively and purposefully, as we would do with choices we make with our children, for which schools we place them at, who we get to look after them, which friends we allow them to join. Okay? So the right care for people living with dementia, there's 4 important factors that we have to take into consideration. And we're going to talk about this progressively as the presentation progresses. The first important aspect that we have to look at is the stage of the disease. It's very important for you to look at the different stages. You have your early stages, your middle stages, and your later stages. And we can speak more about that in the chat if you are interested. Then we have to look at safety of the elder person that's living with dementia. We also then have to look at the caregiver capacity. So you and I, everybody who's watching this presentation, we are all caregivers when it comes to looking at our people that are living with dementia. And the final thing that we have to look for, financial planning, because every decision that we make has a financial implication to it, be it small or be it large. There is a financial implication with that. So where do we start? As with everything, we start with communication. In the early years, we start with the person's wishes. I myself am not brave enough to actually have this discussion yet with my children. This is why there is so much of education and awareness, because we need to start talking about these things. If the person is in the early stages, we discuss their preferences. Do you want to stay at home or do you want to be in a care facility? The answer will always be, I want to stay at home. So we're going to look at creatively, how do we do that? We look at cultural decisions, we look at religious decisions and their lifestyle preferences. We also need to start talking about end of life wishes. What happens if you reach that stage where you cannot make those decisions for yourself? Who makes those decisions? Do I make those decisions or are you going to write them down? Then we need to put into place legal plans that we have, a power of attorney for your finances, for your health. Do you want hospital treatment? Do you not want hospital treatment? Do you want to come home before something happens to you, before you pass on? And your will and your estate planning. These are things that we very rarely talk about, but they reduce conflict and there's less uncertainty later. Not forgetting, as time passes, we need to assess current needs regularly. Because dementia changes over time and we said it's ultimately life-threatening, we have to keep reassessing every few months. This is why communication in the family is so important. We have to do it along every step of the way as the elderly person progresses with their dementia. So we look at some key areas that you're going to need to assess when you are having discussions, and key areas that you need to assess when the person is now living with you with dementia. First of all, it's their daily function, and I'm going to go into these a little bit more in depth because they seem to be difficult concepts to grasp, but they are very elementary concepts. Then we're going to look at safety risks for the elder who's living with dementia. And then we're going to look at medical needs. I'm not going to be focusing a lot on medical needs. I'm sure we have a doctor on our panel here this evening. If you have questions with regards to that, we will take those and respond to them to the best of our ability. Then we're going to look at cognitive and behavioral symptoms. They sound like very daunting terms. I'm going to break them down for you. Then we're going to look at the caregiver capacity. That's you and I and everybody else that has a decision to make. Something that we also need to do. It's measures that we use in a State Department tool that's provided for us in order to assess a person's dependency level. And those are your basic things. Like I said, it's
So, sorry to interrupt, Melaine, but I'm not sure if you're having connectivity issues because we have lost your sound. Are you still with us, Melaine?
yes, I am. I do apologize for that. I have no idea what happened there.
No, you were just so brilliant and so audible, and then yeah, and then the
I don't know. I
gremlin
have
set
not.
in.
I mean, my
That's
son's
fine.
room, and it's when I spoke about bathing, I think maybe the geyser affected it. But so your bathing is
Okay.
affected. Little things that the difference between a shower and a bathtub, those things make such a difference when it comes to somebody living with dementia or Alzheimer's disease. First of all, can they remember to bath? Do they know how to do it? Are they afraid to stand under a shower? Are they able to step into a bath? All those things need to be taken into consideration. Your dressing. Are they able to mobilize and put on their undergarments? Are they able to put on a shirt, button shirts, little things that they lose the memory of how to do? Your eating, do they remember to eat on time? Do they remember to chew? Those become important later in your later stages of dementia where people forget how to chew. Swallowing becomes an issue. Are they able to do that? Are they able to remember that I need to go to the toilet? Are they able to regulate their bowel functions? Are they able to find the toilet? Transferring is also very important. Transferring means can they wake up from their chair to a standing position? Can they wake up from their bed to a standing position? Can they move from a bed to a chair? Those are the aspects that we talk about when we speak about transferring. When we measure mobility, are they able to walk? What pace?
Okay, Melaine, we've
Sorry
lost
about
you
that,
again.
ladies and
Yeah,
gentlemen. We'll try to get hold of Melaine to see what the problem is.
thanks, Vash.
Thing?
Okay, Melaine, we've lost you. We didn't get much after mobility. So maybe you're going to have to repeat from the point of mobility. Are you hearing me? Melaine, are you there?
Cyrilla, her screen is frozen. I think she's got connectivity issues.
Okay, I'm going to, let me connect with her. Dr. Narsi, good evening. Thank you for joining us.
Namaste and good evening.
Oh, namaste.
Happy
Thank you
to
so
be
much
here.
for making the time. I'm not sure how much of Melaine's presentation you got. But whilst we get Melaine back on track, would you like to add a point or two?
So I think I might have just heard Melaine. Do you want to just check again?
Okay, is Melaine back? Let me just
Yes,
check.
I am. I've just put my video off just to make sure that I don't break again.
Okay, you're reducing the bandwidth. Okay, all right.
Yes.
Thanks, Dr. Narsi. We'll continue with Melaine. Okay, thanks. So Melaine, I was saying that we didn't hear too much after transferring. So maybe you
Okay.
want to recap.
Okay. With regards to we've done transfer, let's do mobility. Mobility may seem an elementary issue for those of us that can use our hands and our feet. When we assess mobility, we are looking at, are they safe moving from point A to point B? Are your stairs stable? Are your carpet tiles stable? These are all the things that we're looking at when it comes to mobility. Hygiene also seems an elementary thing, it's a very simple, basic thing when it comes to us who are able to use all our faculties. With people living with dementia, teeth brushing, do they remember to do it? Are they remembering to brush their hair? Cutting of nails is also so important because if we're not able to do that, infection can set in and then we get all kinds of diseases when we have nails that are unkempt. Medication management, do they remember to take medication? Are they taking the correct dosage of medication? When it comes to communicating, depending on which parts of your brain are affected by the Alzheimer's disease, are they able to communicate how they feel, what they need, what their requirements are? Are they wanting to go to the toilet? Are they wanting to drink water? So those, although they're very simple and they are basic, but those are the activities of daily living that we use to assess a person depending on their stage that they're in. The second part that we look at is your wandering. Okay, it's your safety. So wandering refers to, can the person leave home without somebody knowing that they've left home? Is your home secure? Is it safe where they are? Is there somebody to monitor and supervise them? Falls is one of the geriatric syndromes that we focus on a lot as well because it leans on transferring, on mobility. When older persons have a fall, it's a cause for alarm because you never know why they're falling. Are they over medicated, under medicated? Are they dizzy? Did they trip? So all those things need to be taken into consideration. It's your basic things that we take for granted that we need to be on high alert when we're looking at people living with dementia. Are they leaving the stove on after they've made something warm? Are they leaving taps running? These are all danger signals that tell us that safety is compromised. Your door locking. Is their doors locked in the evenings? Are their windows open? Is it safe that their windows are open or shut at certain parts of the day? Up and down stair climbing is one of the most important things. If we're living in a home where there's 2 floors, are they able to access the bathroom upstairs or the bathroom downstairs? Access to your homes. Do they need to access stairs in order to get from point A to point B? Are there guardrails on your stairs? Your bath and shower safety that I spoke about earlier. These are dangerous things that will compromise a person's safety. Are they able to regulate the temperature of the water? Are they bathing on time? Then aggression and agitation are things that we find that will place a person at risk and affect their safety. If people around them and the caregiver does not understand aggression or agitation is common with people with Alzheimer's, people are bound to react. This is why it's so important for us as a family to sit together and outline to our families, young children, teenagers, that aggression and agitation may happen and find ways in which we can cope with the safety aspect of aggression or agitation. With regards to a person's medical needs, are there comorbidities? Are there other illnesses, diabetes, stroke, mobility problems? Then you got the medication that they're taking for those ailments as well. Is that contributing? Is that affecting them? Are there side effects that are affecting your Alzheimer's medication? Is the person visiting hospital frequently? And why are they visiting hospital frequently? Then I spoke about our cognitive and our behavioral symptoms. We need to monitor. Are they having bouts of confusion, bouts of forgetfulness? Are they having hallucinations? Remember, hallucinations is when a person sees or hears, sometimes feels or smells things that is not really tangible, that other people cannot see or feel or hear. Your delusions are the belief that something is out there, and that often is a gateway for paranoia, where they feel that somebody's out to harm them. We need to monitor and assess their sleeping times, their sleeping problems. Are they sleeping on time? Are they having a proper sleeping pattern? Then you have your sundowning in the afternoons. How is their behavior changing in the afternoon? Aggression we spoke about previously as well. That is also cognition and behavioral issues which regularly find themselves because of the patience that people lack when it comes to Alzheimer's, people living with Alzheimer's. And then there's anxiety. Remember, if a person's world is getting smaller, and if they're confused about who's around them, and if they're forgetting their environment and the familiarity is not there any longer because their world is shrinking, that can place an older person in distress and give them a whole lot of anxiety that we need to keep an eye out for. Then we need to assess your caregiver. That's you and I and everybody living with the person who's living with dementia. Are we physically exhausted? Are we coming home from work and having to prepare meals, medicate our elder person? Are we just physically exhausted because we're doing it all the time? The emotional stress of having to keep up with all the information that is out there with regards to Alzheimer's, all the different symptoms that they're presenting. This creates a whole lot of emotional stress for us. The financial strain of having to make sure that our homes and the people around us are feeling good, everybody is safe. If we have to label stuff, that's a financial strain. If we have to bring in somebody else to assist us with cooking, cleaning, that's a financial strain. Your time availability. If you're coming home from work and you only have the evenings to look after your elder who's presenting with dementia, how available are you? How much of time do you have? Is your entire weekend taken because you're looking after your elder? And then balancing work and home. That's also another issue that we have to look at. Your family dynamics. Are there family members who are able to and willing to assist? Is the person your in-law? Is the person your direct relative? All these things play an important role when it comes to measuring how we are coping as a family when it comes to people living with dementia. How do we get to the point where we look for higher care? This specific and precise warning signs. When an elder starts wandering or getting lost, when they fall frequently, when we notice that there's aggression or severe agitation, when you or I become exhausted or we become depressed, when there's incontinence, when our elders cannot decide, when they cannot feel when they need to go out, when they cannot regulate their bowels or their bladder, and there's associated skin problems, when there's poor weight, poor nutrition, they're not eating on time, and there's resultant weight loss, because if you do not eat on time, your medication is not going to work. And are there repeated hospital visits? These are the questions we must ask when we're looking at making a decision for higher care. So what does higher care look like? We call the higher care the continuum of care. What I want you to always remember, it's not where the person lives, but it's more important how well they live with dementia. So we have 4 types of care that we're going to look at today. The first one is your home-based care. That is your least restrictive and your most empowering continuum of care atmosphere. Then we're looking at your assisted living facility. Then we're looking at our frail care. And lastly, we look at hospice care. I'm going to look at all of these a little bit in depth, and I've kept it very, very basic. With your home-based care, your elder lives in your home. Here, care is given at home, and it's important that you employ a qualified and an accredited caregiver with whom you can contract to meet the daily needs of your elder. You must make sure that the caregiver is supervised by a qualified nurse and or a social worker who will come through and monitor every few weeks how the caregiver is doing and how the elder is doing. Home adaptations are extremely important. Labeling your light switches, making sure your hot water and your cold water is labeled, making sure that your rooms are labeled. If your elder cannot remember where the toilet is, label the toilet. This is the toilet. Your home adaptations with regards to guardrails, getting up, standing up, having support when they move from point A to point B. This environment is familiar to the elder, and this is why we call it your least restrictive and your most empowering environment. Then you have your assisted living facility. In this category, your elders, they can conduct some of their daily living activities, but not all. For example, they can eat independently, but they're not able to prepare their meals because we don't feel that they're safe to prepare their own meals. They may be confined to a wheelchair, but they're not able to transfer from wheelchair to bathtub or to shower. And they may need some assistive device, which is your commode, your walker, your wheelchair. Some elders are mobile, but safety is a concern because we spoke about wandering and they may need supervision to go from point A to point B. Some elders appear independent, but they forget to take their medication, they forget to maintain hygiene, and they forget to have their nutrition, they forget to eat. Assisted living has proved to delay the progression of dementia because of the stimulation and the social interaction that we provide within these settings. Your frail care facility, in this category, your elders, they're unable to conduct any of those activities of daily living that I spoke about, and they're completely dependent on others for care. They often require supervision and attention for their well-being and their safety. Most of these elders are confined to either their bed or to a wheelchair. Frail care can be long-term, and at TAFTA, we've had instances where people have lived in frail care for many, many years, but because they thrive under supervision, their lifespan is increased. Here, we give them specialized attention, they get social interaction, and stimulation is present. There's longevity, dignity, and increased hope in your frail care facility. It's very different from your last category of care. On the continuum, it's your hospice care. And your hospice care facility is your specialized and your short-term comfort care for patients who have terminal illnesses and they have a limited life expectancy, which is typically 6 months or less. I've done a little table. You can see the tree of life is prevalent here. Simple decisions that you have to make when you're moving from home to a facility. We're going to look at the yes, because what we want to encourage is for our elders to live within an environment that they're familiar with, which is least restrictive and most empowering. Now, we know our elders love to hear cars, they love to hear dogs, they love to hear children, they love to hear our neighbors. So how do we keep them at home for the longest time possible? We look at, first of all, our first marker is your safety. Are they safe at home? Are they wandering? There's no major falls. They're not leaving the stove on. They're not getting lost. If none of those things are happening, we leave them in our home. If those things are happening, then we need to look at their daily care needs. Can they perform their activities of daily needs? If yes, then they can remain at home. If not, unfortunately, we have to looking at another facility. Then we're looking at our level of supervision. Do they need supervision most of the night? If not, we're okay with them to remain at home and we can increase care. If yes, we need to consider a facility. Then we need to look at the fourth step, which is our medical needs. Are their medical needs complex? If yes, then we need to look at a higher level of care. If no, our caregiver capacity, again, that's you and I. And this is one of the most and financially. And comfortable at home. Some of the mistakes that we often make and some of the emotional considerations that we have to take when making decisions. Now, all of us are guilty of these mistakes. I started with a disclaimer and I said, I have not spoken to my family about future plans. One of the
Sorry,
most important,
Melaine.
yes,
I'm so sorry to interrupt you,
yeah.
but we lost you a bit in that previous slide, and that is such an important slide. Do you
Okay,
think you
let's
can
go
take
back.
us back? Yes,
Yes,
please.
definitely
Thank
we
you.
can do that. I'm glad you're liking my tree.
I'm just
So,
loving it. Thank you.
so we spoke about these 6 things earlier on. We spoke about safety, the person's ADLs, their daily needs, their safety level, supervision, their medical needs, and the caregiver capacity, that's you and I, and lastly, the quality of life. If the person is safe at home, there's no wandering, there's no major falls, there's no stoves that are getting left on, there's no taps that are overflowing, and the person is not getting lost inside and outside the house, then we're safe. We can say, let's carry on at home with home based care. If it's no, let's look at what else we can do. We can consider your other continuum of care, your home based care or your frail care facility. Then we go on to activities of daily living. If they can perform all the activities of daily living, we say yes, we continue with home care. If no, we have to progress to level 3, which is the level of supervision. Are they safe at home during the day or the night? If not, we increase the caregiver. If yes, we consider again your assisted living or your frail care facility. Then we look at step 4, which is your medical needs. Are their medical needs increasing? If yes, we look at again our frail care facility or our assisted living facility. If no, then we assess a critical step, that's you and I. Are we coping physically? Are we coping emotionally? And are we coping financially with our person living with dementia in our homes? Your quality of life, is the person socially engaged and are they comfortable at home? Can I move now?
Yes, you may.
Thank you. So I mentioned some of the mistakes we often make. I said, I myself have not had this discussion with my children about what happens when I'm older, which is right around the corner. But I just want to highlight some of the mistakes so everything's out there and we don't feel judged and we don't feel as though we're the only ones doing it. Everybody makes this mistake. We wait for the crisis to happen. And we know we do this. We live on a hope and prayer and faith, and we say nothing's going to happen, everything's going to be fine. But with the symptoms that I've shown you, this is some of the things that can happen, and we must not wait for the crisis to happen. And then we make the mistake of being the savior, be all and do all. We believe that we must do everything ourselves. Not true. That's absolutely not true at all. And then one of the most important mistakes that we make is that we choose a place instead of a type of care. So remember, on our continuum of care, it's not places that you're looking at necessarily, it's the type of care that you're actually looking at. So we're looking at some of the emotional realities that we often overlook when it comes to making a decision of this nature. We almost always think that moving a person to a facility is something that we're doing that's bad. It's not bad, and it's not abandonment. It's a safety decision because we've discussed several slides ago how important safety is. And it's also a way to protect the caregiver's emotional and physical health. And sometimes, as I've said before, it improves the elder stability due to the routine and the structure that's available at some of our care facilities. Caring for someone with dementia, it's not a test of love. Our main aim is to make sure that even when their memory fades, love, warmth, dignity, safety, and connection remain. People living with dementia, they may forget many things, but they will never ever forget how we make them feel. Some of the resources that you can contact and your 2 main starting points are, of course, TAFTA. I'm an ambassador for TAFTA. Here we offer you counseling, assessments, practical care, how to label your home, how to make your home, safeguard your home, housing for your elder person, and home services where you can receive either meals or a home-based carer. And these are very often affordable for us. And then you have Alzheimer's South Africa, who can give you diagnosis support, education, and caregiver groups. And these are our contact details for TAFTA. You are most welcome to call our intake social workers who will guide you along to the right path. And that is me. Thank you.
Wow, thank you, Melaine. That was amazing. Thank you for your insight. There's multiple complex layers to unpack from your presentation, and careful consideration is required. I'm sure that the audience have questions or comments. So at this stage, I'll hand over to Cyrilla to facilitate, and Dr. Narsi will be invited for his input as well. Cyrilla?
All right, so thanks, Vash. Thank you so much, Melaine. That was quite an eye-opener, actually. I'm sure the audience you have lots of applause going on. Can you see that? Isn't that wonderful?
Absolutely.
So, well done. So I just want to allow the audience to please input or post your questions in the chat function, please, so that Melaine will respond to your queries. I was wondering, Melaine, I know that you have presented this range in terms of what would be a mild stage of dementia, and obviously we're more interested in how this affects the functional ability of the patients, and then the safety risks that follow. But at what point should any of us be concerned, and then where do we start? Do we take the patient off to the GP, or where does the consultation begin?
So we have those markers that we need to look at. Forgetfulness is your first marker when it comes to Alzheimer's and dementia. Remember, there's no blood test that can tell you whether a person has Alzheimer's or not. It's your symptoms are the things that you can visually see, not necessarily something that comes up in a blood test. So that is why it's difficult to diagnose somebody with Alzheimer's. And this is one of the biggest challenges that we have. So I think your first point would be to reach out to a social worker and let's together monitor symptoms. So we're looking at symptoms like forgetfulness, confusion, hallucination, delusions, paranoia, the inability to mobilize, the inability to make decisions. And remember, we said it's progressive. What we do then is not to halt it, but we can delay it. And there's a whole lot of a variety of techniques that we use as social workers to then build a person's cognition, build their reserves, so that we delay the progression of Alzheimer's. So your 4 stages are quite difficult for somebody to remember. You have to go through it. And this is why I said assess regularly. So you assess every 3 months. So it's very, very important for you to either link up with Alzheimer's SA, ADASA, or a social worker from TAFTA. The minute you start fearing that something is not right with the older person that's living with you.
Okay, thank you for that. So I'm just wondering if Jay, do you have any questions, or are there any questions in the chat? Jay?
Okay, now it's just, now I have one question. How do you manage and plan care for a family member with dementia who is resistant to support or intervention? Because in such situations, boundaries can become blurred, particularly when trying to balance respect for the person's autonomy with concerns for their safety and the potential risk of elder abuse. So how do we create that balance and deal with someone who's resistant for care, long-term care?
So I think let's be honest, if I lose my keys and my children say to me, is the Alzheimer's setting in, I become very angry. So at that point, we do not tell our elders, you have Alzheimer's. We don't diagnose them and we don't label them. And that is very, very important because it borders on us judging them and patronizing them. And we refer to that as elder speak, sometimes in elder care. And we also can say that it's ageism to an extent as well. So we have to find creative ways in which we safeguard our elders, where we know that. So keeping your ears and eyes peeled all the time, assessing regularly is so important. If you know that your elder is vulnerable to certain behaviors and there's certain things that may put your elder at risk, you're going to have to find creative ways as a family to address it without bringing it to the older person's attention. Because remember, when you label something, when you tell them you have Alzheimer's, already the distress sets in, anxiety. They want to now, and our elders are very tech savvy. They're going to go onto Google and look at Alzheimer's, and they're going to now analyze themselves in the worst case scenario. Diagnosis is going to happen, and that is not what we want to do. We want to encourage as much empowerment as possible. So slowly we bring into changes into the home. I've already said to my husband, at some point we're going to need to change the step into something that is a little bit more accessible for us. So if family does things like that in a playful way, that's not judgmental and not condescending or patronizing to our elders, I think that's the best way to actually work with it. But the best advice I can give you is you need to reach out to a social worker and isolate. There's a myriad of symptoms that people living with Alzheimer's and dementia present. If I start listing those, you're going to be very, very surprised. So I think it's very important to access a list of symptoms, keep it with you, and mark off, these are the symptoms that we're finding with mom or dad now, and speak to the social worker. How do we safeguard ourselves? To some extent, sometimes we're going to have to hide scissors away from them because we're not feeling safe for them using a scissor or a knife. So there's different extremes to the rate at which the disease progresses. And I think looking at a person as a person throughout the progression of this disease is the most important thing that's going to make all of us feel dignified and all of us have the best quality of life, whether you're the person living with dementia or whether you're the person providing the care. So reach out to a social worker. That's the most important thing that I can't emphasize it anymore.
Okay, so thanks for that, Melaine. Jane, are there any other questions?
Ayushi, I think Ayushi has a question.
All right. Go ahead, Ayushi. Oh, where's Varsha? Varsha, why am I doing your job?
Hello, Melaine. I think you're doing an incredible job there. Beautiful presentation, very detailed, very practical, informative. I just have a few questions. I don't know if I should just ask you like in one go and then you can answer them maybe.
Sure.
Okay. So I have this one question about, does muscle memory work with dementia patients? Like if we have repetitive activities, throughout the day, we have a set routine. Will that help coping with dementia patients?
I think I'll answer your question as you give it so that all of us don't forget before the Alzheimer's set in.
All right.
So your brain is essentially plastic. There's a whole lot of research going on with Alzheimer's. And I will just make this point very, very clear. Alzheimer's is not a new disease. It's just that it's a little bit more prevalent now because we are talking about it. So it's been around for many, many years. So with a lot of the research that's been done, one of the recent things that's come up is that your brain is plastic. So you can determine how much you take in and how you build your own cognitive reserve. Now at TAFTA, what we're doing at the moment is we're trying to develop a system of games, a little booklet of games that we can all play when we talk about active aging from the age of 45, 40. That's my age at the moment, actually. Okay, so from that age, we start looking at active aging where we start building our cognitive reserve. Games like Sudoku, games like crossword puzzles, your word scramble, all those games that build your muscles in your brain. Those are the things that we need to start developing from a very, very young age, from the time that we can start forgetting stuff. So your brain is plastic. It does have muscle memory. The other thing that we also need to remember is that when Alzheimer's sets in, you forget the most recent events. And then progressively you start losing your older memories. So when we do an exercise with people to build empathy for Alzheimer's, what we do is we ask them to write down a role that they've played in their life. We've asked them to write down one of their values, one of the places that they've loved to be, and then we remove those things. And that's essentially how Alzheimer's works. It depends on which parts of your brain are affected. And then we start developing your cognitive reserve with regards to those parts of your brain. But I'm sure Dr. Narsi has a better answer than that, if Dr. Narsi can assist. But we'll go to your second question.
Okay, thank you so much for that. What are the early signs that the caregiver may show that he or she is experiencing burnout? And like, how do we recognize now that our caregiver is now experiencing this pain? And what can we do to help?
It's essentially when first of all, they're going to be looking tired. Secondly, they're going to become very, very short and impatient. And ultimately, the empathy is going to go. So they're not going to have the same commitment that they have with the elder person. This is why I said when we're looking at home-based care, we need to look at is the person getting support? Is there care for the carer? Is the person having somebody else to take over that shift? Is the person having enough time to focus on their own self-care? Remember, with caregiving is associated self-care. So the family needs to come together and monitor the person that's providing the care, if that's informal care within your home. And if it's formal care, there needs to be a contract with the organization that's providing you with the carer. That carer gets monitored by your nursing services manager and your social worker at regular intervals. Does that help you?
Yes, it does. It does. Thank you. What's one skill that a caregiver must have? Okay, like we say, take a deep breath. So what is that one basic sentence or a word that a caregiver must remember at all times?
That this person is dependent on me to meet their needs and to keep them safe. The most important thing is the safety aspect and the dignity. And as long as we can provide safety and dignity for our elders living with dementia, I think that feeling that they have of completeness and belonging, I think the word you're looking for is, I need to make sure that this person feels like they belong. So doing your regular tasks is not the most important. Making them feel like they belong, even just a touch of their hand, just sitting with them. And also just something else that occurred to me today is experience. We don't measure it with time. We measure it with the small moments that make up the time. So in as much as we say, I've got 5 years experience with Alzheimer's and dementia, you can do just one act of smiling at somebody, and that is an experience that your elder person remembers for the rest of their life, the feeling that they get from you having smiled at them. And this is why we say to our staff at TAFTA all the time, when you meet our elders in the lift, make sure you greet them and you smile at them, because that gives them completeness and it makes them feel like they belong.
That is so true. Thank you so much, Melaine. You have answered all my questions. Thank you very much.
Thank you so much.
Thanks, Ayushi. Dr. Narsi, would you like to just maybe just add to the presentation or just your comments on the presentation?
Thanks, Sarila. It was really a comprehensive presentation. Thank you so much, Melaine. There's actually very little to add. because I think you have covered all aspects, and me basically saying anything now would essentially be repeating everything. So I think it was quite well done. Maybe what I can just do is just, allude to some of the points that, or rather, some of the questions that Melaine answered, and maybe I can give some input now if that's not going to be too distracting. Would that be fine?
Yeah,
Sure.
please go ahead.
Okay, so apologies in advance for this because I might just be all over the place. You're actually testing my memory right now on, so yeah, I can probably then look at where do I fit in on that trajectory. But maybe let me just start off with Ayush's question about muscle memory. It's a very, very interesting question. And yes, we all do have muscle memory. Muscle memory does work in dementia. And in fact, Melaine did allude to some things. And I think what's most important is that people require routine. And I'm not even qualifying this by saying elderly individuals. Everyone requires a routine. It's very nice and it's very cool to be spontaneous. But really, what keeps us well, what keeps us healthy, what keeps us grounded is having a routine. And that routine actually assists in building muscle memory. And, you can call it muscle memory, or I prefer to call it routine, regular cognitive routine. The more we entrench that in people, the better it is. So even in an individual with dementia or Alzheimer's, the more time you spend actually in developing a routine for this person, doing things on a regular basis, having a set daily timetable, things that are very, very predictable for this person. And again, I like the fact that you brought in muscle memory because the routine should not only be cognitive, whereby you're thinking at this time I do this, or at this time, I expect my family to come home, etc. It should also be active, meaning that you should be able to link a particular routine with an activity. So, for instance, when someone comes home, I need to do this. I need to maybe open the door, or I need to, go out and meet them, or say a certain amount of things. Or so having some active routine which involves activity is extremely, extremely important to build muscle memory or to build cognitive routine. So I hope that answers that. I think Melaine answered the question about cognitive burnout caregiver burnout quite well. And then Ayushi asked for a magical word or a magical phrase that maybe can assist caregivers. In my opinion, there's just one magical word, which is self-care. You really, really cannot pour from an empty jug. And a demented individual is only as well as their caregiver. So, this is something very important to recognize in yourself. And Melaine has mentioned all the signs of caregiver burnout. So, if you recognize any of these signs, there's no use being a hero. Reach out for help, because this might be important not just for you, but also for the people that you're caring, the elderly individual, as well as for the others that are in the house, as well as for the people at work and every other person that's involved in your life. So I think reaching out for help is also quite important.
I think another word that I actually want us all that's listening to remember is empathy. Now, we've embarked on a project at TAFTA where we get you to walk in the person's shoes. You get to put on a pair of goggles that our teenagers are wearing, and you get to see and feel exactly what they go through. So when vision goes, when that part of the brain is, the occipital lobe is affected and your vision goes, you can actually walk through a corridor and see how minimized and diminished your vision is. So your empathy is something as well that I want to leave us all with. It's if we don't know how a person feels and if we haven't walked in their shoes, it's very, very difficult for us to, like Dr. Narsi said, pour from an empty cup.
Yeah, those are real gems. Thank you. Thank you for that. I think
Hi,
the
hi,
other
can I
point
say
that
something?
sorry.
Hi, can I say something?
Parita.
Sasha?
Hi,
Sasha?
it's Rita, Sarala.
Oh, hi. How you doing?
Okay, good. Sorry,
All right.
I just wanted to make some comments. Is it possible?
Yes. Go ahead.
Oh, okay. So I just wanted to share. Hi, Melanie. It's Brita. We actually
Studied together.
studied together. So we actually run a memory clinic at Inkosi Alba Lutuli Hospital, and I just wanted to share that it's quite a team approach to intervention. So we have on that team the neurologist, the geriatric doctor, specialist, the psychologist, a psychiatrist, social worker, and So when we receive the referrals, there's quite a bit of comprehensive investigations that goes into it. So there's quite a bit of diagnostic testing that gets done, coupled with other memory tests that they run with the patient. And we also have the psychologist that would do the neuropsych testing. And the neurologist will then share the diagnosis with the family. And we sort of take them through quite a bit of follow-up as well through the continuum of care. So I just wanted to share that we do have a memory clinic. It's an dementia Alzheimer's clinic, and they do the diagnosis and they do the medical counseling and they do the psychosocial support coupled with the therapy that's required for the family, as well as psychosocial support for the family as well as for the patient. So I just wanted to put it out there that we do have the service that is available for patients challenged with dementia and that kind of thing. Yeah.
Can I just ask, Badita, who does the referral? Is it your GP or can a social worker do
Okay.
referral?
So what really happens is it goes via the doctors. So the doctors would contact the geriatric doctor or the neurologist, and they would go through some pre-screening, and they would sort of like accept them into the memory clinic. So there's appointments that are given. So yeah, there will be some screening that will happen between your referral doctor with our team of doctors as well.
Thank you. That's very interesting to know.
Yeah,
Right.
so
thank-
and we do quite a bit of journal club presentations, and we have the clinic running every Thursday of a month. And then we do have follow-ups that occur between various, sort of role players in the team. So there is an active memory clinic that is happening at Inkosi Alba Lutuli. And there's a foundation called Bessie Makatini Foundation. We also work with the Alzheimer's Association, and we also liaise with TAFTA and that kind of thing. Bessie Makatini Foundation has an online support group, and they actually do quite a bit of work with the families and empower the families in terms of giving information and dealing with their concerns and that kind of thing. So in addition to the psychosocial support that is given by the social worker to the family, there's also the support group that happens on an online basis as well. So yeah, just wanted to share that with yourselves of a resource that is available. Yeah. Thanks, then.
Okay. All right. So thank you so much. Thank you so much, Barita. Thanks for sharing that. So if there were many years ago, I also worked at the memory clinic, and it's really a valuable resource, which in many instances seems a bit underutilized. And I think it's because the patients have to come through the public health system. So perhaps we should actually get the geriatrician from the memory clinic on board on our next session, just to give clear directives in terms of how more people can be accessible to that clinic. But it's really a valuable service, and it gives a provides a very comprehensive diagnostic and management procedure. So yeah, thanks for sharing that, Barita. Before we go on, there have been so many support structures that you've mentioned, yourself and Dr. Narsi as well. So I'm just hoping that between Jay and Varsha, they will collate this and keep them as resources in the chat function. But Dr. Narsi, I see you need to add one, you're asking to add one other point. You may go ahead.
Thanks. Yeah, I just wanted to sensitize people that, there are a lot of unscrupulous homes that are out there, or geriatric facilities. So I think it's very important to ensure that, the facility you refer to or look into is properly licensed. Definitely a social worker can assist you with this, but it's also important to, just go yourself, check, ensure that the facility is registered with Department of Social Development. And I've added a website in the chat panel, which I think is quite a nice a set of resources. It has a list of all registered, licensed old age home facilities, geriatric frail care facilities in the country. So you can actually filter your search depending on where you are, what you're really looking for. Thanks.
Wonderful. Thank you for that. That's a really valuable resource. So I think what we will do, though, is that we will collate. Parita, if you can just also add in the chat function those facilities that you mentioned, so people can reference those as well, please. All right. Let's see. Aisha, are there any other questions? We're running slightly over time.
Yes, Saralaji, there is, Zetu has asked a question. Well, okay, she asked about if TAFTA is the only place, but we know now there are more organizations and places that people can go to. Zetu also wants to know how accessible is TAFTA to the local community?
So this excites me to let you know. The numbers that I gave you earlier, the 031 332 3721, that's a number you contact. So at TAFTA, we've embarked on this very widespread awareness when it comes to Alzheimer's. And I think we know why, because of as Dr. Narsi had spoken about, unscrupulous organizations, but also the myths surrounding Alzheimer's. So we've embarked on this widespread awareness campaign. So we're accessible to all communities. All you need to do is just telephone that number. And even if there is no support group in that area, a social worker will reach out to you, offer you information as to where there are support groups or which social worker you can contact with regards to Alzheimer's and dementia. We've created a very, very simple brochure for both young children, teenagers, and for other caregivers, adults that are living with people who have dementia. So we are very, very accessible. We've been, if you go on Google and you ask for elder care, the first place that's going to come up is definitely TAFTA. So just dial that number or send in an email and one of our intake social workers will contact you, regardless of the area in which you live in.
Thank you so much, Melaine. I also see Anati also got a hand, but she hasn't asked the question. I think she wanted, I'm not sure if she's online now, if she can ask a question. You can type it in.
Actually just welcome that in the chat.
Yeah. Okay. Yeah, I think there are no more questions here.
Hi, Melanie.
Hi,
everyone. I wanted to, I'm a social worker working with older persons in a residential facility. I wanted to ask on the part of safety, where we ensure safety. I work with the residents within the facility, and within the facility, we do have cottages as well, where because it's retirement village, where now we get our clients, not our clients, I don't want to say patients, but where they are part of the village, but now we do assessments with those residents, and then once we notice that there's changes in terms of the memory, in terms of hygiene and stuff. So, and then that's where we look at these things, and then we determine what a person needs to be placed with frail care because they can't look after themselves, be it they are staying with a partner because it's a retirement village. They normally old, like around their 80s or late 80s, early 90s. And then now they have to be admitted with facility, a frail care. Then we face some difficulties there, where in terms of safety, we are not sure, we don't have like the actual policy in place that protects us. Well, we know what we are doing. Like I work with matrons, with staff nurses, to get a person under under care, to get proper care for the person. But then now we tend to like fumble around safety. We're not sure, we don't have a policy that will protect us when we do our job, to protect the residents and the residents around that particular patient. So my question is, do we have any policy in place that will protect other residents, that will protect us as service providers or as caregivers?
So,
Thank
Anati,
you.
it's a pleasure. Thank you so much for your question. We work with the Older Persons Act and the regulations thereof. They may be very daunting policies that you have to look at. It may be very bureaucratic and red tape, but I'd advise you to read those regulations, all regulations associated with residential care. You're going to get a lot of assistance from there. You can also call me on the numbers that I've given you, and let's talk about it. But I'm just a little bit concerned about us having no choice but to, if a person already has a partner and we're looking at no alternative but to move them. From the four continuum of care that I've looked at, something that we must always remember is your least restrictive and your most empowering. Where is the elder familiar? So you're going to look at aging in place. So even if they have Alzheimer's, it does not necessarily or automatically mean that a person needs to move into a frail care setting. Put in those measures into the home, empower the partner as to how to make sure that that person is safe, teach them coping skills and coping mechanisms, and also provide with them with all the home-based care support that you can give them. Teach them about transfers, mobility, turning the person, how to feed them, how to get them into a routine, how to build their cognition, how to, all those little things that we spoke about today. So best alternative. In the community, not everybody can afford to go into a frail care facility. We know that reality of that. So we encourage aging in place, and your aging in place is your home-based care services with an empowered caregiver and your meals that are provided on time, in full, so that medication is optimized. So not necessarily to move a person away from their familiar environment, because then we are decreasing their lifespan and bringing them distress and anxiety. So I just needed to add that as well, Anati.
Thank you so much. We do have that in place. We always make sure that a person is kept in their familiar environment for as long as possible. Well, I make sure of that, and we make sure we do have alternatives. Well, alternatives to care while they are still at home. What forces what forces us having to move the person is when it gets to aggression, like when a person becomes so aggressive that they end up abusing now the partner, or hitting the partner, or disturbing the neighbors. That's where it gets out of control, where now a person, because you're wondering as well, we do try, they are locked gates. The person can go around the village. We do have security, so the place is safe. But now when it gets to that part where a person's aggression cannot be controlled,
Anati, I'm
and
going to have
sometimes
to
when you
stop you there,
receive,
sorry, because I think
mm,
perhaps you will need to take this up with Melaine at a later stage because we were looking purely
oh,
at
thank you.
a different topic today. But I'm sure you can
Oh,
take this
thank
up with
you.
Melaine if you don't mind, Melaine. I
I
think
will
Anati
be.
will be
No
better off
problem.
reaching out to you.
Sure, I'll be available.
Okay, thank you so much for that. Thank you, Anati. Okay, ladies and gentlemen, we'll now close the meeting. So I will now pass a vote of thanks. And during the vote of thanks, a poll will appear on your screen. And we ask that you please take a minute of your time to complete this, as your feedback is important to us. We'd like to express our sincere gratitude to Melaine Pillay, who without any hesitation accepted our request to participate in the webinar. Thank you, Melaine. You've given us valuable insights on the topic, and we deeply appreciate your time and expert advice. And thank you too to Dr. Nasi for your participation in the discussion. We extend our gratitude to the Arya Samaj administration, Radio Hindvani, and to all of you who shared the invitation on social media platforms. The contribution of the Arya Samaj Women's Forum executive is acknowledged, in particular, the chairperson of the forum, Dr. Cyrilla Ramklas, and the members of the executive committee, Ayushi, Jay Sheila, Lipika, and Shruti, who have worked collaboratively to ensure the success of this event. In addition, I'd like to thank our tech assistant, Sadhna. Thank you, Sadhna, for creating the amazing video at the introduction, which showcased the events that have been hosted by the Arya Samaj Women's Forum. Look out for our advert for the next session on brain health, preventing dementia, which will be held in May. Be safe, be protected always. Thank you and namaste.
Okay, thanks, Rasha. Thank you very much,
Thank you.
Melaine. Thank you